Good afternoon, everybody. Thanks so much for joining today. We're excited to share information about our healthcare delivery innovation competition. We wanted to start by introducing ourselves. So my name is Anna Steer. I'm a policy manager at JPAL North America here at MIT. I manage our U.S. Healthcare Delivery Initiative, and I'm your primary contact for any questions about the competition. I'm joined today by Mary Ann Bates, Executive Director of JPAL North America.
Hello, we're excited to have all of you here and really looking forward to hearing your questions and having a conversation both during this webinar and afterwards. So thanks for joining.
So before we dive in, a few notes of housekeeping related to the WebEx. You've all been muted, but we encourage you to use the chat function, and you can just send any questions to all panelists. And we'll have some time at the end to answer your chat questions. And we are recording this presentation as well, and we'll be posting this to our website within the next week. So today we're going to cover an introduction to JPAL. I will then talk about the broad outlines of our innovation competition and what we are hoping to achieve with it. I will then talk about when randomized evaluations are appropriate, and that is the specific focus of our innovation competition. I'll then turn it over to Mary Ann to talk about an exciting ongoing project in South Carolina with the Nurse Family Partnership. And then last but certainly not least, I'll walk through how to apply to the competition and some details about what makes a strong application. And we'll leave time at the end for some Q&A with all of you. So thanks again for joining. So JPAL's mission, broadly speaking, is to reduce poverty by ensuring that policy is informed by scientific evidence. And JPAL really started in the international development context by bringing a rigorous approach to figuring out what really works in alleviating poverty. And our work falls roughly into three major buckets. The first is evaluations. So we have a broad network of affiliated academic researchers who partner with governments, nonprofits, and other organizations to work on rigorous evaluations. Our specific focus is on randomized evaluations, or RCTs, as they're commonly referred to, and we'll talk more about that a little bit later on in the webinar. The second bucket of work is policy outreach. So we have staff here that synthesize a lot of existing evidence and share results of studies with policymakers and others that can act on that information. So for example, we put together a brief synthesizing some different approaches that work in combating the opioid epidemic. And last, we also do training and capacity building for both researchers and implementing agencies on how to do these kinds of evaluations well. And here at JPAL North America, we're really focused on evaluating social policy programs here in the U.S. context. So as I mentioned, our network consists of more than 150 affiliated professors from 49 universities, and they're all really committed to using randomized evaluations to test the effectiveness of programs and policies. And we have over 50 researchers who are primarily health economists that are specifically interested in studying healthcare delivery in the U.S. So next I'm going to talk about the competition, but before we jump into that, I'd like to give some context about our broader work in this space. So as you all are aware, there's a great deal of discussion about how to reform our healthcare system today, and we think it's really crucial that this conversation is informed by evidence and that the scholarly community is engaged in research questions that are directly applicable to policy. So the research partnerships that we form in this initiative can help to answer these important questions about the directions public policy should take to best improve our healthcare system. So this was the first main research initiative that we launched when the JPAL North America office was formed. And one of the main reasons we focused on that is because there was a disconnect when we saw that most medical interventions, 80%, are studied, medical treatments are studied with randomized controlled trials. And that really wasn't the case with healthcare delivery. Only 18% of studies in a review of the literature were really studied in that rigorous way. So while we expect that when we see medical treatments, we expect that they're studied using randomized evaluations, we really weren't seeing that in studies of the way healthcare delivery works in the U.S. So what does our initiative do? We help develop rigorous evidence of strategies to improve the quality and value of healthcare delivery, and we do that by funding randomized evaluations, connecting policymakers, practitioners, and researchers, building evaluation capacity, and then last but not least, disseminating evidence to policymakers. And the photos on this slide are pictures from a conference we held in 2016. So this map demonstrates some of the partnerships we've had, both past and present. We've had a chance to work with a really wide range of organizations and government agencies to date. And one way we build these partnerships is through our innovation competitions. So the goals of this innovation competition are to catalyze rigorous research to develop compelling and reliable evidence of innovative programs in the healthcare delivery space in the U.S. And we also want to build the capacity of healthcare organizations to both create and use rigorous evidence. And then our last goal is to facilitate connections between academia and implementing organizations, and hopefully having them partner together on rigorous evaluation. So how do we do that? The competition is an opportunity for organizations to apply to receive technical support from JPAL staff. So in the early stages of research design, that might mean help refining the research question, conducting calculations to determine what sample size might be needed, helping find appropriate data sources, and other discrete tasks like that. There will also be opportunities for online and in-person training on evaluation and what makes a good evaluation and how to best conduct them. And we'll also be doing kind of hands-on matchmaking with our network of researchers. And then applicants that successfully partner with a researcher from our network can then jointly apply for funding for randomized evaluations. So next I want to touch on when randomized evaluations or RCTs are a good fit. As you may know, there are a number of ways to measure impact, and we really see RCTs as a tool among many in a toolbox. With this, we understand that RCTs are a really good tool in some sense, and they may be better than other tools in certain situations and vice versa. So the way we think about what RCTs can be particularly useful for is that they're a credible source evaluation method that can cleanly identify causality, and it's also fairly easy to explain. That doesn't necessarily mean that it's the best research tool, but it's one that we particularly focus on. So since randomization requires fewer assumptions, we can be more confident that the impact we estimate reflects the actual impact of a program. And we won't go into the different methods today. We're going to just talk a little bit more about RCTs in particular. So what is a randomized evaluation? So imagine you'd like to test the effectiveness of a care management program in reducing emergency department use. The hospital where you'd like to test this intervention doesn't have enough resources to serve everyone who might benefit, and they're not sure yet whether the program is effective. The circle represents the total population that might be eligible for that program. Individuals from that group are then randomly assigned into a treatment group that gets the care management program and a control group that does not. The the two groups continue to be statistically the same. The only difference is that one group received the care management program and the other did not. Because of that random assignment at the beginning, any differences in outcomes between the two groups can be attributed to that care management program. So you have a way to establish that a causal effect of your program. So when are good times to consider randomization? So we have a few bullets here we want to go over that provide some hopefully helpful context on when randomization is a good fit. So first, an unstudied or understudied program might benefit from a randomized evaluation, so a program that has not yet been rigorously evaluated. Or a program or service that is oversubscribed. So if you can't serve everybody, random assignment can be a fair way to allocate those spots. Or a program that's expanding, so moving into a new location, a service area, or new target population. Adding a new component or service, so can you roll out that new component to some folks but not others, and so testing the effects of adding that new component. Or a program that has very clear eligibility thresholds or cutoffs, so those just below or above that cutoff could be randomly admitted into a program. And, you know, conversely, sometimes randomized evaluations really don't make sense. So when you have a sample size that's too small to pick up an impact, so that's a common question we get. You know, this really varies on how intensive a program is and what you anticipate the effect size to be. But in general, you usually need at least 100 people as a general rule of thumb for a randomized evaluation. If your program is still ironing out the logistics and you don't have a very clearly defined program, that also might not be the best time to do an RCT. Or if you're already serving everyone who's eligible and you hadn't put randomization in on the front end, that also means an RCT is probably infeasible. And of course, if a positive impact has been proven and you already have the resources to serve everyone, then a randomized evaluation really isn't the best choice. So with that, I'm excited to turn it over to my colleague, our Executive Director, Mary Ann Bates, to talk about her experience on an ongoing evaluation.
Thank you, Anna. Welcome, everyone, and as I mentioned before, I'm excited to hear more from you, and please feel free to chat your questions throughout, and then we'll address them at the end. The goal of the next section is to talk about one specific evaluation that we're running here at JPAL North America to put a little more detail on the overview that Anna just gave. So what does it look like in practice when a service provider decides to build a randomized evaluation into a program that they've been running? So I'm going to talk about an evaluation that I'm personally involved in South Carolina. I also want to mention the two JPAL-affiliated professors who are leading this are Maggie McConnell, who's at Harvard, and Kate Baker, who's at Chicago, in addition to numerous colleagues here at JPAL who are running this. So let me give a bit of background on why this study was started and how it came about, because it has a kind of unique story and was pretty exciting for us to be able to be involved in. So the motivation for this is that the state of South Carolina was wanting to implement effective programs addressing challenges in child well-being. So the image you see here is from a report from the Annie Casey Foundation, which found that South Carolina faces numerous challenges for child well-being, including problems of low birth weight babies, learning disabilities, and a variety of other things. And the goal of the state was to focus on evidence-based programs and then to find partners and creative funding solutions to increase the services that are available in South Carolina for new moms and their children, and in the process to generate evidence that can focus future resources on programs that really are effective. And the program that we're evaluating is one called the Nurse-Family Partnership. Many of you might be familiar with this one. The pediatrician David Olds started this program many years ago, and at its heart, it's basically a home visiting program. So nurses are paired one-on-one with first-time mothers who are low-income and face a number of challenges. And these nurses are trained to be nurse home visitors and to provide information, support, advice, and a supportive relationship with the mom throughout her pregnancy and up to the child's second birthday. And the program, through these visits, they can provide information on infant feeding, on resources available like WIC or supportive housing, connect them with prenatal health care providers. So think of it as kind of this wraparound comprehensive service that rests on a foundation of a relationship between a nurse and a new first-time mom that is intended to empower the mother to improve outcomes for herself and for her child. And the context for the evaluation we're doing right now rests on prior evaluations that were done. So Dr. Olds was very visionary and conducted multiple randomized evaluations of his program starting in the 1970s and in the years thereafter in different contexts. And all three of the experiments that they ran found significant positive effects on outcomes like healthy birth spacing, reductions in preventable childhood injuries in the first few years of life, and even in long-term outcomes related to the mother's financial stability, income, schooling outcomes for the children, and so on. So this has been flagged as an evidence-based program by the Coalition for Evidence-Based Policy. Ron Haskins' book, Show Me the Evidence, tells the story of how the credible evidence behind this program played a large role in increased federal funding for home visiting programs, and it's also been mentioned in past economic reports of the president. And so this all coming together is part of why, as Anna mentioned at the beginning, we've found that randomized evaluations can be very persuasive, especially when they show measurable positive effects of a program in helping people decide to shift resources towards those kinds of programs. So why are we looking at this today if there have already been so many evaluations of the program in the past? Well, there are two main reasons. One is that the context today might be different from a number of decades ago. So for example, if overall levels of smoking have changed, which can be a key driver of birth outcomes during pregnancy, might that change the effect of this program? If access to family planning resources are different, how might that affect how this program influences those outcomes? So we expect that, decades later, there might be different effects and on different outcomes than we might have seen in the past. And the second major question that we're interested in looking at is, what is the effect of a program when it's taken to scale? When it's being scaled up, including through creative financing mechanisms, what effects might we be able to find? So we at JPAL were excited to get involved in the study because we felt it was a rare opportunity to study a very important topic at a reasonably large scale and potentially discover quite new and nuanced findings that can be helpful not only for the Nurse-Family Partnership and how they refine their programs, but more broadly for people interested in maternal and child health. So the context in South Carolina specifically is that there was potential to expand. The Nurse-Family Partnership is already established in South Carolina. They have 9 different implementing agencies where they employ nurses who are working across the state and serving new mothers, but they were only reaching a small portion of the potentially eligible new mothers each year. And so they had capacity to expand the program because they already had this established infrastructure in place and felt confident that they could expand while maintaining fidelity to the original model. And then we had the ability to be a part of this novel expansion through a number of creative financing mechanisms. So one was the availability of paying for services through Medicaid for the first time through a Medicaid waiver that the state of South Carolina applied for at the federal level, and that was done in connection with a pay-for-success contract. So the basic idea behind a pay-for-success contract is that ahead of time, the state and a group of investors and the service provider, in this case the Nurse-Family Partnership, agree ahead of time that if certain metrics are met and a certain threshold is exceeded, for example, in reductions of preventable childhood injuries, then the state will make success payments back to the program. So it's an innovative financing mechanism that can be used to expand programs while building in accountability and the ability to measure the effect of the program rigorously. So both of these components, both the Medicaid waiver and the pay-for-success contract, hinged on having a rigorous evaluation of the impact measured by an independent third-party evaluator. And in this case, they specifically specified that it would need to be a randomized evaluation, because the state of South Carolina, Department of Health and Human Services, felt strongly that they wanted to have the strongest possible causal evidence to know whether the effects that are measured in the evaluation correspond with what happened in the real world. And so they specified that it would need to be a randomized evaluation. And so this is, the evaluation and the pay-for-success contract was key for this expansion in South Carolina. Part of the reason that my colleagues and I were interested in doing this specific evaluation is that we see enormous value more broadly. Beyond this specific, what we'll learn specifically about this program and even South Carolina, the scale of this evaluation will enable us to, we believe, test the impacts in a pretty nuanced way, in a way that we hope will be very helpful and influential for healthcare policy more broadly. So next I'll talk about the wide set of partners involved. In this specific evaluation, the Nurse-Family Partnership Pay-for-Success Project, some of the key partners are, you can see at the top, South Carolina Department of Health and Human Services. The NSO is the National Service Office of the Nurse-Family Partnership. Then you have the local implementing agencies across the state of South Carolina, and many others, the philanthropists, the different organizations that are working together to make this happen, in addition to JPAL North America as the independent evaluator. And getting that many partners on board and agreeing to do an evaluation together can be challenging, but it's also been a tremendous opportunity. And part of what I think has really helped in pulling together so many different partners is that there are shared goals. One was the shared goal of expanding the Nurse-Family Partnership with a particular focus on underserved rural areas. So one creative aspect to this evaluation is that they built in a target to ensure that a certain percentage of the women enrolled in this program during the study come from what they call low-income zip code areas. So these are areas that are harder to reach. If you think about a program that has nurses driving individually to home visits, doing that in a rural area where your clients are very spread out takes a lot more time and is much more challenging than doing it in more densely populated areas. But the state cared quite a lot about ensuring that as the scale-up happened, it didn't just happen in the areas that were easiest to reach, but also the harder to reach areas. So this is one thing that people sometimes wonder about when they're considering doing an evaluation is, well, if I randomize, do I give up all sense of discretion and control about how I target this program or who I really want to reach? And sometimes there are things like this that can be built in that still help you achieve your goals in terms of who's being served by the program, depending on the priorities you have. So the second shared goal that all the different partners, the investors, the state, the Nurse-Family Partnership shared was that they were really interested in assessing how the Nurse-Family Partnership can change outcomes for the mothers, can change outcomes for the children, and can potentially change how resources are being used and accessed. To what extent does this help vulnerable moms access new resources? To what extent might it actually reduce expenditures, for example, in Medicaid if preventable childhood injuries are reduced, for instance? So these were questions that were of interest to the state, to the funders, and also to the Nurse-Family Partnership. And kind of tying that all together is an interest in generating rigorous evidence to inform future decisions about where our resources can be allocated, expanding the program payment rates, and things like that. So let's talk about the nuts and bolts for a little bit. This is a basic outline of how study enrollment happens. So how do we go from the idea of saying we'd like to know the impact of this program to actually building in an evaluation that can give us an answer to that question? So the first two boxes in orange look quite similar in some ways to what the Nurse-Family Partnership had been doing prior to the study starting. as before the study, they recruit potential clients to serve through the program from a variety of channels. It might be from a healthcare provider. If a newly pregnant mother comes to see a healthcare provider, they might let her know about the Nurse-Family Partnership Program, or the WIC office might, or they might learn about it from a friend. And when they then contact the Nurse-Family Partnership or they reach out to them, eligibility can be assessed. Would this be this woman's first birth? Does she meet the income eligibility? Is she in a certain window of pregnancy where NFP is able to enroll her? And that eligibility processes we kept fairly the same from what they had previously. And then what changes, what used to happen before the study was running, is that there would be a wait list. So if a mom met the eligibility criteria, she would be added to a wait list, and if they had a slot available prior to someone on the wait list kind of aging out of the program and being too far along in their pregnancy to be able to enroll in the program, then they would be able to be offered a spot. Now what happens when someone has determined that they're eligible for the program, then the Nurse-Family Partnership nurses reach out and do the next 3 steps in green, which are part of the study. They collect informed consent, so they tell the mother that there's a possibility to be a part of the study, and then do a baseline survey where we ask questions and get identifying information that can help us follow people and data later on, and ask basic questions that help with the analysis, and then the randomization occurs. So a computer-generated random number will basically determine whether there's a spot for the woman in the program or whether she will be a part of the control group and receive business as usual care. Overall, over the course of 4 years, we'll be enrolling 6,000 women into the program. We're almost halfway through. We've enrolled about 2,500 women so far and decided to have a 2-to-1 ratio. So 4,000 of those women will be in the treatment group and 2,000 will be in the control. And this is another example of something that we did in response to requests from the Nurse-Family Partnership, who felt that it would be helpful to have not just a 50-50 ratio of, you know, when service providers learn about this program and say, should I refer people to the Nurse-Family Partnership, they felt that if they could say, yes, you know, if you refer someone, there's a 2/3 chance we'll be able to take them in this program, that would feel different from saying it's 50-50. Now, the specifics of how one designs this niche evaluation depend on many factors that we can work through in each case. But in this case, this was something that we were able to do and build in, and the Nurse-Family Partnership felt that this would be helpful for them. And then once they're randomized to both groups, we'll look at outcomes for both groups, and I'll talk about that in a moment. Now, what this means in practice in how the enrollment is done, I mentioned before that the nurses are the ones who are doing the study enrollment. This is in some ways an unusual way to do an evaluation. What is kind of the typical case is that research staff enroll people into a study, and then the service provider provides the services. When we first talked to the Nurse-Family Partnership, one of their priorities that they let us know about in the first meeting, if I'm remembering correctly, is that they said it's really important to them that the first contact with the mothers that they're serving be done by their nurses who are from South Carolina, who live there locally in the community and really understand the clients that they're serving really well, much better than research associates who work for JPAL might coming in from the outside. And so we developed an enrollment system on tablets. All that I mentioned before around baseline survey, informed consent, and the randomization happens on a tablet-based system that we've designed and that we monitor remotely. But the nurses are the ones who are in the home with the mothers doing all of this. And what this means is the nurses wear 2 hats, right? They're wearing the hat of a researcher and the hat of a nurse home visitor, which in some ways can be challenging for the nurse to have to switch back and forth during that first visit and saying, you know, here I'm going to do a baseline survey and be an objective researcher and asking you these questions, but also wanting to establish a relationship with this client that they might be working with for the next 2.5 years. But the Nurse-Family Partnership, we have many conversations with them as we develop this study. They felt that the benefits of having the nurses have that in-person connection really outweighed any challenges, and so that's why we designed the study in that way. Now, what outcomes are we looking at? Once enrollment happens, as I mentioned, and a spot is available for a mom in the program, from that point forward, the evaluation sort of recedes to the background from the perspective of the nurse and the mom, who are now going to spend up to 2.5 years having visits with each other. And that's because we're using administrative data, meaning data that are already being collected primarily by the state of South Carolina for other purposes to look at the outcomes of the study. And this minimizes the burden on participants because we're not going back to them repeatedly asking them to meet with us and complete new surveys. And it minimizes the burden on the service providers who don't have to send us forms specifying every time they have a visit with a mom. We simply pull that data from the Nurse-Family Partnership's existing data systems. And so what does this mean in practice? Well, for example, if we want to know the effect on preterm birth, we're drawing vital statistics records for the treatment and control group moms and can use that to see the rate of preterm birth in the treatment group and the rate of preterm birth in the control group. Similarly, later on, if we look at birth spacing for subsequent births, we look at vital statistics, again, for both groups. For childhood injuries, we can look both at Medicaid records and an all-payer claims database that the state of South Carolina has. And for these other outcomes, we can look at other records, again, across the state of South Carolina, across different departments and agencies, and link them all together to create a pretty comprehensive picture of how this program is changing the lives of the mothers. So let me take a step back now and talk about, why are we doing this evaluation? And the first point is that it's not about giving an up or down verdict on the Nurse-Family Partnership or its flagship program and saying either it worked or it didn't. But really the goal is to try to be creative in the design of the study and the kind of data that we're collecting to learn about key questions, to understand, how does a program like this change outcomes and in what way? Does it seem to change outcomes more for the child or for the mother? Or does changing outcomes for the mother really seem to influence outcomes for the child later on? There are many, many nuanced questions that are more about the why that we really hope this study will help us uncover, and in the process hopefully create a lot of evidence that the Nurse-Family Partnership can use in refining its programs and that other organizations and policymakers can learn from as well. So now a few common questions that we get when we're talking with people who are considering what kind of evaluation they might want to do. One is, do I have to freeze innovation on my program to do a randomized evaluation or a randomized controlled trial? And the short answer to that is not necessarily. So as one example, the Nurse-Family Partnership is continuing to refine its service delivery model over the course of the 4 years. They're trying out different strategies to make their operations more efficient, to reduce the cost per visit, and they're doing that over the course of the study. So we will measure the average impact across the 4 years, given that they are making some of those changes. Similarly, the whole strength of this program is to give nurses the flexibility to figure out what a mom needs in that particular moment. So it's a very structured program. They have a curriculum that has lots of different topics they cover, but doing this evaluation didn't force them to freeze that in place. So a nurse still has the flexibility if the curriculum says, visit number 7 was planning to talk about different infant feeding mechanisms, but now that I'm here in the middle of the nurse home visit, I actually feel that what the mom really needs to talk about is housing because this challenge came up. The nurse still has that same flexibility that she had prior to us coming in and doing this evaluation. So what we're measuring is, what's the effect of a program when you have a trained professional who's using her discretion to provide services across up to 2.5-year period. The second question we get a lot is, does my organization have to collect all the outcome data points of interest? So for instance, at the start of this, the Nurse-Family Partnership might have been thinking, well, if we want to know the impact on birth spacing, we don't have touch points with the moms in all cases for a long term, how would we know when they subsequently might have further children? We don't necessarily have the data for that in our systems, and that's okay. We're not getting that data from the Nurse-Family Partnership. We're getting that from the state vital statistics records, and that's something where we as researchers can facilitate getting those data use agreements in place and linking the data. And then the data that the Nurse-Family Partnership does have is their very specific data on, when they're providing nurse home visits, what the content of those visits were, and we're able to port that from their data systems very efficiently as well. So it's possible to think about your organization if you think about the impact that you think your program has, even if your organization doesn't have access to all the data you might need to see that, it might be possible to link with data that other entities, for example, government entities or other entities are already collecting. And the last point I wanted to make here is just that these evaluations are often, they're always a big partnership. So the picture you see here is of one of the trainings that we hosted at an event where all of the different implementing agencies in South Carolina were coming together, and you can see the many dozens of nurses and nurse supervisors who are implementing this study across the state. And the JPAL research team is mixed in here as well. And we have many, many touch points with them in terms of our in-person visits. We created a hotline for them. We have continuous trainings throughout the year and are constantly listening to them. What are the challenges that you're facing? Before we started, we piloted all the different survey tools with them, with both them and the people they were serving, to figure out, how can we ask the questions in a way that you think is the clearest, and how can we design this program to really fit well with your needs? So I'll wrap up by talking about how this process typically works in terms of deciding whether an evaluation is a good fit for your organization and if it might be a good fit for partnering with JPAL. So the first two steps, the first two boxes, are really at the heart of what this innovation competition is all about. So the first step is determining the feasibility. Does an evaluation make sense for your organization at this point in time, and what kind of evaluation? Do you have the sample size where it would make sense to randomize? Is your program currently oversubscribed? Some of the things that Anna mentioned. Our staff, Anna and her colleagues, can work with you one-on-one to have some of these conversations and figure out, does this really make sense, or maybe would later be a better time, or would a different kind of evaluation be a better fit? So we're happy to help work with you on that. And then the next step is to see if you do think it's feasible to do a randomized evaluation, can we match you with a researcher who shares similar interests? So when we started talking with the state of South Carolina and figured out, wow, this is a great opportunity, it looks like it's feasible, our next step was to then go talk to people like Kate Baker and say, are you interested in taking on this evaluation? Would you be interested in leading this? And sometimes we can be quite helpful in making that match. And then the next two steps kind of happen beyond the competition. One is analyzing historical data that can help you figure out the nuances of what sample size you might need and other design questions. And then you and the researcher jointly can apply for pilot funding from JPAL to help kickstart the evaluation. And in some cases, if it's a light touch, low cost evaluation, might cover the full cost, or position the study well to apply for additional funding from traditional sources. So that's kind of in a nutshell how this process can work. Happy to answer other questions at the end, but I'll turn it back over to Anna.
Thanks so much, Marianne. So I just wanted to reiterate that you can continue to ask questions via the chat function. Make sure to direct your questions to all panelists. But I'm going to continue by just talking a little bit about how to apply for this innovation competition before we open it up to Q&A from all of you. So as you all know, we are now inviting letters of interest from healthcare organizations. And this is really available to any kind of healthcare organization that has an innovative program that they'd like to test. So whether that's a government agency, a health system, a health plan, a nonprofit organization that delivers, healthcare services, things related to the social determinants of health, there's really a broad range of organizations that could be a great fit for this competition. So to apply, you submit a 3- to 5-page letter of interest that describes the policy question or challenge that motivates your application, the specific intervention or program that you're interested in evaluating, how many people your program currently reaches, whether you see a potential opportunity for a randomized evaluation and how that might work, and what kind of data you have available for measuring the outcomes. So as Marianne mentioned, it's not necessarily the case that you need to already have that in place, but it's helpful when we're reviewing applications to have a sense of the data that you already collect. So I touched on this at the beginning of the webinar, but I just wanted to reiterate, why we think this is a great opportunity for healthcare organizations. So finalists will receive technical support from JPAL staff to help really think through the design questions of a randomized evaluation, and provide some training opportunities so that you and some other staff members at your organization have a chance to really dive into, why evaluate, why RCTs can be a valuable tool, and then how to actually conduct, at a high level, randomized evaluations in practice. And we also, as I mentioned at the beginning, have this broad network of researchers who are really interested in partnering and engaging with a wide range of organizations to study different innovative healthcare programs. So we have staff here who can help put you in touch with those interested researchers, what we like to colloquially refer to as matchmaking. And so we're really experienced at this process and can hopefully help set up a successful partnership. And then we have, twice a year, we run a request for proposal process. So the partner that matches with a researcher can jointly apply for funding through that process. And as Marianne mentioned, I'm really here to answer any and all questions as you put together these proposals. If you're not sure whether your organization is a good fit, or if you have questions about, what makes a strong application, please do feel free to reach out. So a high-level overview of the timeline. So March 2nd is the deadline to submit letters of interest, and applicants will be notified that they're finalists on the week of April 23rd. We're then going to be hosting, as part of our matchmaking efforts, a training workshop here in Cambridge in late June, where we'll bring together the finalists as well as researchers who are interested in matching and partnering on these projects. So that will be a really exciting event that will combine both training and matchmaking. And our next regular request for proposal process will begin in September. So I do encourage you to go to povertyactionlab.org/HCDI for more information, and we have a specific page related to the innovation competition that has links to the letter of interest form, as well as frequently asked questions. So we've developed some resources that will hopefully help you as you put together these proposals. And lastly, before we turn it over to Q&A, I just wanted to highlight a few of the characteristics of a strong application. So, I think what we're really most excited about is that these projects can have the potential to meaningfully improve healthcare delivery in the U.S. And as you might expect, given that we are the Poverty Action Lab, we're particularly interested in programs and issues that have a disproportionate impact on disadvantaged populations. So we're really looking at programs that address questions crucial to understanding pressing health policy issues and that are potentially scalable and translatable to other contexts. Also, as I mentioned when talking about feasibility, having a very clearly defined program and knowing what outcomes you're interested in measuring are also going to be something we're looking for as we review these applications. And feasibility, of course, as we continue to reiterate, is really, really key when you're talking about something like a randomized evaluation. So we'll be looking at the potential sample size, the availability of data, and your willingness and the feasibility of randomization. And lastly, I want to underscore that the organizational capacity and commitment are really important. As Marianne touched on, when you're working with diverse stakeholders, it's so important to have support from senior leadership at your organization for working on an evaluation like this. And so having adequate data systems, support from senior leadership, adequate funding for the implementation of your project. So while we can, down the road, potentially help with evaluation funding, it's important to have, a funded program that you'd now like to test, and the administrative capacity to implement the program at the scale that you proposed. So with that, hopefully that was a good overview of this innovation competition and what's involved in applying. And now we're, continue to please send in questions via chat, but we'll go ahead and get started with a few questions that have come in. All right, so one question is, will the slides be available to the participants? And the answer is yes. We'll be posting this recorded webinar back onto our website, and so you'll see the slides there. We're also happy to send out a PDF version of these slides to all those who signed into this webinar after. Thanks.
This is Marianne. I'll take one of the next questions. One question was, if we do not have a specific program for evaluation, can we still submit a proposal to work together with JPAL for capacity building? That's a great question. And sometimes it even happens that, organizations who do have a specific idea for an evaluation apply to the innovation competition, and then we might jointly decide that perhaps it's not the right time to do that evaluation. What can we still do together? And the answer is we do actually have a number of capacity building activities that might be a good fit. One example is that we host an annual executive education course here at MIT. It's a week-long intensive course that goes into kind of the nuts and bolts of how to think about evaluation from start to finish, with a then specific focus on how to think about randomized evaluations. So that might be a good fit. There are also a number of other lighter touch capacity building activities that we often do through the process of applying for an innovation competition, or even just in parallel. So if you have a specific question about this, if you have a specific content or materials or a training that you think would be a good fit for your organization, please reach out to Anna and we can discuss that on an individual basis. But we have quite a few resources either already available, or we can have a conversation about what you might need.
Great, thanks, Marianne. So a related question is, can I work with JPAL on project development in the future if I won't have a project ready by the deadline of March 1st, and what would that look like? So building on what Marianne just said, that's absolutely something that we do on an ad hoc basis. So certainly we do the kind of matchmaking that I described that will be done as part of this competition. We also do throughout the year. So I do encourage you, if you don't have a program that's ready right now to be written up into a proposal, but you think that down the line you might, feel free to just keep in touch with us. We're happy to provide, support in any way we can, either through capacity building in the meantime, like training or webinar type capacity building activities. We definitely want to be a resource, and we're really happy that there's engagement and excitement so far from various organizations.
Another question is, how do I generate buy-in for doing this kind of evaluation among staff in my organization? I think there are a couple of ways to think about that question. One would be that starting with the objective of why you want to do an evaluation in the first place. Are there key questions about the impact of your program where you have some uncertainty and you really want to know, we're hoping that this program improves outcomes, here, here, and here, but we can't be sure. And starting with the question that you want to answer and involving your team in talking about why it would be incredibly valuable to have a reliable answer to that question. I think another way to think about this is to also be very honest from the start about kind of the opportunities and challenges that come along with doing an ambitious evaluation. It will take some time and effort, including from the leadership, to think through carefully what kind of evaluation do we want to do. And it might be that, we learn something that surprises us, right? Perhaps the impact we thought we were having, we're not having in quite the same way, and perhaps, we're having positive impacts in areas we hadn't considered. But just to, from the beginning, help the team understand that when one does an evaluation, we often are surprised and can learn something new, and that's a good thing, not a bad thing. So those would be some ideas, but would be interested in hearing. I'm sure there are many other ways to frame this as well.
So another question we got is how this relates to our state and local innovation initiative. So you might have heard that we have a concurrent innovation competition. And it's structured a little bit differently, but there are some important ways that they overlap, and they have some of the same goals. So our state and local government initiative is really intended, it's not a healthcare specific competition, it's related across many different sectors, and there's a period, more intensive technical assistance that comes along with that innovation competition. So currently, the state and local government innovation initiative is working with multiple jurisdictions around the country on homelessness-related projects, and they are looking for their next cohort of jurisdictions to work with. In some cases, if you're a healthcare agency, we're on the phone thinking about whether to apply for the state and local competition or this one, please go ahead and reach out to either me or Julia, whose contact information is on our website, about which one is a better fit. It kind of depends, but you are technically eligible for applying for either one. But I encourage you to reach out, and we can think about the specific case on a case-by-case basis, which would be a better fit.
Great. Another question that came in is asking if there's no one in JPAL's network that's particularly interested in evaluating a program, or no one has bandwidth to take on a new project at that time, do we consider expanding the network to assure a breadth of research interests are covered? So the short answer to that is potentially. Now, there are times when it may be the case that there's an interesting program and it's just not a right fit for researchers in our network, and we want to be very honest about that. We're not always able to be successful matchmakers. We aim to do that, but it's sometimes possible, it sometimes isn't. But the second answer to that is that, yes, we do expand our network over time, and as Anna mentioned, we now have over 50 different researchers who are specifically interested in health issues in the United States, and we have been growing that. We launched the North America-focused branch of JPAL only 4 years ago, and so that is growth that we've seen just in the last 4 years alone, and we're interested in continuing to expand the group of researchers that are there. We are based at the Department of Economics here at MIT, and so many of the people in our network come with a background in economics, and that's our primary focus, but they often partner with and many times collaborate with people who are in different fields, including public health and medicine and different areas. That's a great question as well.
So the next question is, at what stage in the program or intervention is the application strongest? For example, if we want to pilot an intervention before statewide implementation and want assistance in evaluation and design early, should we apply, or are you looking for programs that have a longer history? That's a great question, and this is exactly the kind of thing that we're also happy to discuss on a case-by-case basis. Piloting is a great way to get involved in a randomized evaluation, especially if the results of the pilot suggest that there's interest in scaling it further. So I would say that absolutely you can have a strong application, even if what you're proposing is more in the pilot phase. But that shouldn't preclude you from submitting a proposal.
And I can add to that a little bit. Sometimes, I think the only case in which you want to be careful about not doing an evaluation too early is if there are a lot of operational details that aren't yet worked out. If you don't want to do a rigorous evaluation, find out there was no impact, and then afterwards wonder, well, is this approach really ineffective, or was it just because there were a lot of operational problems when we were just rolling this out for the first time? On the other hand, if a program has already been rolled out across the state and everyone who could be served by it already has access to it, then that's usually not a very feasible time to do an evaluation either. So it's kind of, there's a range, and we've done evaluations on both ends of the spectrum. So it's a sort of an it depends question, but it's definitely, piloting with the potential for future expansion is often a good time to evaluate.
So I think we're going to go ahead and wrap up here. We wanted to draw your attention to a couple resources on our website that have, some additional information about randomized evaluations and some of our experiences to date with working with different partners. So I encourage you to go to povertyactionlab.org/admin-data to access some of those resources. And then, I'm sure that you might have additional questions after this webinar, so please reach out to me, Anna Spear, at aspear@povertyactionlab.org with any specific questions. We really appreciate your time and your great questions today, and we look forward to receiving your great applications. Hope you have a great rest of your afternoon. Thanks very much.